Hi Doc, I am Ricky Tricia Therese Obadong, and today I am going to show you a case report about the use of inclined planes on children. So the topic that we are going to discuss is about using composite resin inclined plane for the repositioning of a laterally luxated primary incisor. So this case report describes the repositioning of laterally luxated primary central incisor with occlusal interference using a composite inclined plane. Introduction. Primary teeth injuries are common in young children due to their lack of muscle coordination in the early years of life. These injuries primarily affect anterior primary teeth. As a result of the resilient bone surrounding the primary teeth, these injuries are usually luxations. For laterally luxated teeth with no occlusal interference, the preferred treatment is follow-up for spontaneous repositioning. In cases of minor occlusal interference, slight grinding is recommended. So when serious occlusal interference occurs, repositioning with pressure is recommended. However, if repositioning with pressure is impossible because of the time lapse between injury and application, then extraction is preferred. In the case reported here, instead of extraction, a laterally luxated primary central incisor with occlusal interference was repositioned using a composite inclined plane. We have here our case report. A 4-year-old girl applied to our clinic 3 days after a traumatic injury with a complaint of pain and transposition of the left primary maxillary central incisor. Clinical and radiographical examination showed the tooth to be laterally luxated. We have here preoperative radiograph of the laterally luxated tooth and intraoral view of the laterally luxated tooth of showing the luxation in the palatinal direction. Radiographically, neither the root nor the alveolar bone showed any sign of fracture. The crown was displaced in the palatinal direction, and the germ was judged to be safe. The tooth exhibited serious occlusal interference with the mandibular left primary incisor, and the child suffered from spontaneous pain. However, due to the length of time elapsed between the time of injury and the presentation of our clinic, the tooth could not be replaced in its original position in the alveolar socket. Here we have our treatment plan. So the chosen treatment plan consisted of repositioning the tooth using a composite inclined plane following the application of a root canal treatment. The treatment options were explained to the parents who gave their informed consent. The root canal treatment was performed using calcium hydroxide paste. We have here, and the tooth was restored with Compamar. So following restoration, the labial and incisal surfaces of the lower primary central incisors were etched with phosphoric acid for 40 seconds, washed for 30 seconds, and dried. Composite resin restoration material was applied to the incisal surface to form 3 to 4 mm plane inclined at a 45 degrees to the longitudinal axis of the teeth. So the only contact between the two arches was at the incisal edge of the luxated tooth in the inclined plane. Here we have the clinical photograph showing the contact between the incisor and the inclined plane. By the end of the first week, the left maxillary central incisor had moved in the labial direction, but it had only not yet repositioned completely. After 2 weeks of close follow-up, the tooth had returned to its original position, the inclined plane was removed, and the lower central incisors were polished with prophylaxis paste. During the follow-up period, the treated tooth was examined for the percussion and palpation sensitivity, mobility, swelling, periapical radiolucency, and pathological root resorption. No clinical or radiographical pathology was observed. At the 1-year follow-up examinations, the treatment was judged to be both clinically and radiographically successful. We have here the radiograph of the tooth 1 year after the treatment, showing no signs of pathologies. Then, clinical photograph of the tooth 1 year after the treatment. So the recommended treatment for laterally luxated primary teeth with occlusal interference is repositioning with pressure. However, a delay between the time of injury and presentation for the treatment may prevent positioning. In such cases, grinding may correct the occlusal interference. However, if the interference cannot be resolved by grinding, then extraction of the tooth is required. Whereas the grinding procedure can harm the structure of a healthy tooth, the loss of an anterior tooth, especially in a young child, can lead to poor phonetics, the development of bad habits, and loss of function. So in addition, poor aesthetics due to tooth loss can cause psychological and social problems for children. In this case report, instead of extraction, an inclined plane constructed from composite resin was used to reposition a primary incisor with a crossbite caused by lateral luxation. Another method of correcting an anterior crossbite is the use of removable acrylic appliance consisting of an acrylic plate that opens the posterior bite and a finger spring that tips the anterior teeth forward. However, like tongue blades, the success of acrylic appliances also depends on patient cooperation, which is difficult to achieve with younger children. Although the treatment was successful in this case, clinicians should be aware of some possible risks posed by using this method to treat laterally luxated teeth in young children. Then we have our conclusion. The use of a composite resin inclined plane after a root canal treatment along with careful follow-up can be an alternative to extraction for laterally luxated primary incisors with occlusal interference. That's the end of the report.